Welcome to The Green Rush, a podcast about the intersection of cannabis, the capital markets, and culture. On a weekly basis, hosts Ann Donahoe and Louis Goldberg of KCSA Strategic Communications speak with the business leaders, financial experts, cultural icons, legislators, and generally interesting people moving the cannabis industry forward. Today, our hosts are speaking with Dr. Rick Strassman, American Clinical Associate Professor of Psychiatry at the University of New Mexico School of Medicine and the author of the book Dmt the Spirit Molecule. After a 20-year lag, Dr. Strassman was the first person in the United States to again study psychedelics on humans back in the early 1990s, which led him to write his now well-known book on the study's subject matter. One quick note about today's show, there are a few points where Dr. Strassman's audio quality just gets bad. We try our best to conduct face-to-face interviews with the Green Rush when possible, which yields the best sound quality, but sometimes that's just not possible, and internet connections are a fantastic second choice. But as we hear in today's show, sometimes connections can get spotty. Rather than edit out the quick few offending choppy spots, it made sense to just keep them in, as you can usually pick up on what Dr. Strassman is saying, even as audio pixelation sets in. Our apologies there. The good news is that everything that Dr. Strassman has to share is fairly fascinating, so it all washes out in the positive in the end. Now, on to our conversation with Dr. Rick Strassman.
Depression, anxiety, PTSD, addiction, OCD. Nearly 40% of all adults around the world suffer from some form of mental illness. The National Alliance on Mental Health estimates that untreated mental illness costs the United States up to $300 billion every year due to losses in productivity. Mental health drugs like SSRIs, serotonin reuptake inhibitors such as Prozac, Zoloft, and Paxil, along with benzodiazepines such as Xanax, Valium, and Klonopin, are the top 2 or 3 drugs prescribed annually in the United States. We are a nation and a society and a world that is facing a massive mental health crisis. More and more people are living isolated, lonely lives, which are the number one causes of untreated mental health illnesses. And the drugs that are prescribed treat the symptoms of mental illness, but not the underlying cause. And for some patients, these drugs do provide help. But for many people, they aren't even a Band-Aid. And the reason is that these drugs, the SSRIs and the benzodiazepines, which are unbelievably addictive and unbelievably difficult to get off of, don't treat the underlying causes or traumas that lead to mental illness. Well, back in the 1950s, research was done at NYU, Johns Hopkins, and a few other universities on the value and impact of psychedelics such as LSD or psilocybin, or magic mushrooms, for treating issues like alcohol addiction, depression, anxiety, all of these issues that we all suffer from. And the results of those trials that worked with literally tens of thousands of patients over almost 20 years were incredibly promising. But in the 1960s, those drugs escaped the clinic and were brought out into the mainstream by Timothy Leary. We've all heard the phrase, tune in, turn on, and drop out. Well, that scared so many people, including the President of the United States, Richard Nixon. And by 1970, Nixon had declared his war on drugs. And psychedelics, along with cannabis, were assigned the DEA schedule status number 1, meaning that these compounds were deemed to have no medical value, have a high incidence for addiction or misuse, and as a result, all research ended. Well, today's episode is different from nearly every other one that we have done to date. While for more than 100 shows, Ann and I have focused almost exclusively on the business of cannabis, today we're looking at psychedelics. And yes, I know that we spoke with Ronan Levy, CEO of Field Trip Ventures, now Field Trip Psychedelics. And full disclosure, Field Trip is a client. Well, today I am talking with Dr. Rick Strassman, American Clinical Associate Professor of Psychiatry at the University of New Mexico School of Medicine. After 20 years of intermission in research, Dr. Strassman was the first person in the United States to undertake human research with psychedelics, hallucinogenic or other entheogenic substances, with his research on N,N-dimethyltryptamine, or NN-DMT, in the early 1990s. So why am I talking with a doctor who did research on psychedelics more than 20 years ago? Today, we are in what is known as the third wave of psychedelic research. A couple of years ago, Michael Pollan released his book, How to Change Your Mind. And if you're not familiar with Michael Pollan, he's one of the most famous and influential investigative journalists who has been studying food and plants for 30 plus years. And if you haven't read How to Change Your Mind, I strongly encourage you to do so. Following Michael Pollan's book, there has been a massive renaissance in attention being paid to psychedelics and their impact on curing and not treating mental disorders. And this is all thanks to Dr. Strassman, who opened the door. And now organizations such as MAPS, the Multidisciplinary Association of Psychedelic Studies, Atai Life Sciences, Compass Pathways, have all been working with the FDA to increase studies into these molecules. And MAPS has moved the ball so far forward that the FDA has granted MDMA, or ecstasy, breakthrough status, and they are in phase 3 trials for the treatment of PTSD. Psilocybin, or magic mushrooms, are in phase 2B trials for depression. Universities such as NYU, the University of Wisconsin, the Imperial College in London, and UCLA are all doing cutting-edge research. And back in September of 2019, and I don't know when you're listening to this because podcast life has no time, or as Ann says, time is a circular bagel. It kind of comes around and goes around. Well, back in September, Johns Hopkins received a $17 million grant spearheaded by Tim Ferriss to create the Center for Psychedelic and Consciousness Research. All of this is a result of the work of Dr. Strassman and what he did back in the 1990s at the University of New Mexico with a couple of hundred patients. It may be hard to believe, but there is a better chance that psychedelics will receive federal approval for medicinal use before cannabis does, hence wanting to talk with Dr. Rick Strassman. So with that, it is my pleasure to welcome Dr. Strassman to the Green Rush. So Dr. Strassman, thank you for agreeing to chat with me today. Let's jump right into it. Why do you think psychedelics are so in vogue right now?
Well, psychedelics have always been in vogue. With a certain segment of both the lay and scientific community, and their use has stayed pretty constant over the last several decades. Even after they were scheduled in 1970, the prevalence rate of their use among young adults has stayed pretty steady. But I think that with the resurgence of research, which began in the early 1990s, late 1980s, and because of the lessons learned from the first wave of clinical studies, helping people avoid some of the mistakes from the first group of researchers. There's been a gradual mainstreaming of psychedelics into the biomedical worldview. They became a lot more popular, or at least DMT did, with the publication of our book in 2000, and that was still kind of a niche group of lay and scientific aficionados, as it were. Our studies wrapped up in 1995, and also occurred at a relatively small university without a major PR department. So when Johns Hopkins began doing studies and publishing with their PR machine, they those studies got a lot. Those studies got a lot more media attention, and the mainstreaming picked up a lot more quickly. And I think over the last couple of years, one could point to Michael Pollan's book, Changing Your Mind, as especially speeding up the mainstreaming of their use, both recreationally and scientifically.
The Michael Pollan book is what got me really paying attention to the research on psychedelics, and the work that he cited from NYU, from Johns Hopkins, from Imperial College shows that these molecules have tremendous promise in treating the mass mental health issues that we're facing as a society. And there are claims that taking 1 or 2 guided psychedelic trips can cure PTSD or addiction. Can you discuss how psychedelics can provide a cure versus providing a treatment? Like, how do these things cure addiction? How do they cure depression or anxiety?
Well, I think to refer to any cure of mental illness is a little bit hyperbolic. You can make a major improvement, a dent. You could even put somebody into remission where they no longer have got symptoms, but the person still has got the depressive disorder or the bipolar disorder or the addictive disorder. It's just in remission. It isn't like an infection, let's say, where you treat with antibiotics and the bacteria are gone. But still, you could see remarkable improvements in a number of conditions with properly guided psychedelic-assisted psychotherapy. Well, how do psychedelics work? Well, I think the first order of business is to make the point that there isn't anything inherently therapeutic about psychedelics. They are only tools. So you can point to the improvement in depression or addiction with current clinical research, but you can also point to how Charles Manson used psychedelics to turn pre-existing psychopaths into serial diabolic killers, using LSD in another kind of model of psychedelic assisted change in personality or enhancement of the kinds of behaviors, feelings, or thoughts that are sought after by people who engage in those kinds of therapies or processes.
Can you explain the function to it? Because when we read Michael Pollan's book, he takes some time, and others talk about the default mode network. Can you explain what the default mode network is, and then what happens when you have a psychedelic experience?
To be honest, I have not followed the electrophysiology and the brain imaging research all that carefully.
Okay.
I think though to I guess express it in kind of blunt or crude terms, the default mode network is what establishes what regulates or mediates our sense of self, who we are, what we're capable of, what our beliefs, feelings, ideas are, our conceptual ego-based framework of our interactions with ourselves and with the external world. And at least my understanding of the effect of psychedelics on the default mode network is that it loosens those bonds, as it were, and makes one more receptive to ideas or beliefs or feelings that may be potential but have not yet become actual. So you could actually invoke the default mode network in all manner of use and outcomes of using psychedelics. The Charles Manson model, let's say, and the mystical model, which has been touted by the Hopkins group. So what is important to keep in mind is that psychedelics work on the person. They work on the mind. That's why they're called psychedelic, mind manifesting or mind disclosing. So it's the raw materials that the psychedelic is engaging. The personality of the individual, their expectations, their hopes, their fears, their experiences, and those of the people around them who they're taking the drugs with, as well as the physical environment. Those are divided into set and the setting. The set is the individual, and the setting is the is pretty much everything else.
So there was a lot of research that was done on LSD, on mescaline, on psilocybin in the 1950s and the 1960s. And as you said, in 1970, President Nixon declared the war on drugs and made cannabis and psilocybin and a lot of other drugs Schedule I, including the drug that you worked with, DMT. Can we go into the way back time machine for a moment? It's the early 90s. You're at a small school in New Mexico. How were you able to get the FDA and the DEA to approve your research? Did you actually dose somebody in DC, or can you take us through the process of how you got a yes?
Well, I chuckled when you mentioned did I dose DEA. I think that with the new generation of regular, people from, I'm not saying that anybody at FDA or DEA was experienced, taking psychedelics, but nevertheless, they came, or the regulators, the bureaucrats I was working with, were a different generation than those that were overseeing the Controlled Substances Act in the late 1960s, early 1970s. So they were more open to these drugs being studied than than was the case 20 years earlier. It took me 2 years of working with the DEA and the FDA to get my permits. Mm-hmm. The main goal was to establish communication channels between FDA and the DEA. It had been 20 years, since anybody had, basically applied to do human research with these drugs. And there were all these new regulations in place. The main problem was for me to get, my hands on, DMT. I had to find, somebody that would be allowed legally to make it. And, once I had it, I could then, put it through the, paces that the FDA required. So it was a bit of a catch-22. I couldn't, begin the study without FDA approval. FDA approval required that it was a pure, clean drug, but I couldn't, possess the drug to put it through its, paces without, permission from the DEA. But the DEA wouldn't give me, permission until, number one, I found somebody to make the drug, and number two, I got FDA approval, which required, possessing the drug. So it was pretty, what's the word? Convoluted.
It was literally what the Joseph Heller catch-22, right? I mean, you can't get the drug until you can prove that the drug is clean. You can't prove the drug is clean until you get it. I mean, it's this circular. Was that structure, do you think, set up that way to discourage researchers like you from actually getting the approval to do this research?
No. On the contrary, I think everybody wanted me to do this study. but it was just, bollocksed up in the paperwork. Before I gave my first dose of DMT, I got 2 grants, one from the Scottish Rite Foundation for Schizophrenia Research, and one from NIDA. I actually got a grant from NIH, the National Institute of Drug Abuse, to do my DMT study before I got the drug. So scientists wanted me, to do this work. The government wanted it done. The private sector wanted it done. But it was just working through all of the jungle and the morass of paperwork and regulations, which were set up after the controlled, after the Controlled Substances Act, which had never been tested. Those regulations were never applied because because nobody asked to apply them. So it was just a steady chipping away against the edifice. And finally in November 1990, I got a fax from the FDA saying go ahead, happy Thanksgiving.
That's amazing. Why did you pick DMT? And then can you describe what happens to a patient when they take it? Because there had been a lot of research done on LSD and there had been a lot of research done on psilocybin, but DMT was not a molecule that was researched very much prior to you. So why this drug? And then what happens when you take it?
Well, there were 3 main reasons I chose DMT instead of LSD or psilocybin. Or one, it was short acting, and I knew that because my study was going to be pharmacological, quite intrusive, invasive in some ways, and would have to occur in a hospital on a research unit. That if people had adverse reactions to the drug, that they would be short-lived. Another reason is its obscurity at the time. Nobody really knew about DMT, and I thought that any new research with psychedelics, especially well-known ones, would garner a lot of media scrutiny. So DMT wasn't anywhere as well known as LSD or psilocybin. Speaking of LSD and psilocybin, the short duration of action of DMT stood in marked contrast to those of LSD.
And how long is a duration for?
DMT, or you smoke it, but in a hospital setting, it needed to be injected. It's about a half hour as compared to 8 to 10 to 12 hours with LSD, 6 to 8 to 10 hours with psilocybin. And I also chose DMT because it was endogenous. It's made in the human body, and there were some fascinating questions raised in the 1960s, early 1970s about the role of endogenous DMT in naturally occurring psychosis. Perhaps if you blocked DMT's effects, somehow in schizophrenics it would help improve their symptoms. And I also chose it from the vantage point of drug abuse, which was one of the selling points in my grant application to NIDA. Is that people continued using psychedelics. DMT is the prototypical tryptamine hallucinogen, and if we understood its mechanisms of action, that would help provide insights into the mechanisms of more widely used psychedelics, like LSD.
Can you describe what happens to a patient when you dose them or when somebody smokes it? What is the effect?
One thing it's helpful to differentiate between the idea of a patient and a normal volunteer. All of our studies took place in normal volunteers. They weren't sick, they weren't depressed, they weren't suffering from, terminal kinds of illness. They weren't, seeking anything, other than perhaps some increased insight or some curiosity. But, they were mostly participating out of a, sense of altruism as opposed to a, sense of, suffering. As compared to patients who have got, diseases or, disorders that they're coming in to be treated for. So all of our, volunteers were, psychologically healthy, physically healthy. They weren't abusing drugs. The expectation wasn't that, they would be freed of a particular, disorder. So we didn't really prepare people that much. We didn't, do the 10 to 12 hours of session, psychotherapy, for example, which occurs in most of the, psychotherapy studies, which are, going on, nowadays. I just told, people it's fast, it's short. You may, feel as if you've died, but, don't worry, nobody has. And if you get into any problems, we've got a, code team on call. But other than that, we didn't really educate people. This is what's going to happen. This is the way you deal with it. DMT has a long history of this or that. It was just go in, have your own trip, keep your eyes open, so to speak, and report back to us what happened. The typical effect of DMT in our volunteers when a big dose was injected is that people started feeling something within a heartbeat or two. The room started to pixelate. There was what volunteers described as a rush, which was a buildup of inner tension and anxiety, a great feeling of speed and acceleration. There would be a high-pitched, crackling sound, oftentimes. The rush lasted about a minute, maybe 90 seconds, and would culminate in the separation or the feeling of the separation of the volunteer's mind from their bodies. They would no longer be aware of their bodies, and this was quite profound actually, because we would check blood pressure at the 2-minute point and at the 5-minute point, and no volunteer, almost anyway, no volunteer felt that mechanical squeezing, uncomfortable blood pressure cuff inflate at the 2-minute point. Most people didn't feel it at the 5-minute point either. So the dissociation was profound. The visual effects are quite striking, and we discovered early on that those visual effects would overlay the visual world of the room in which the study was taking place. So we figured out pretty soon that we needed to keep people's eyes closed, and to encourage that, we gave everybody those black eye shades to put on before we gave the drug. So at the 2-minute point or so, people would dissociate and enter into this world of light, rapidly spinning and morphing, quite quite bright. It was intensely saturated. They felt as if they were in a world of sentience and intelligence and of information. Sometimes that feeling would coalesce into the perception of discrete or discernible beings, things that we ended up calling beings, which could take any manner of shape or form, humanoid or plant or insect or even sentient buildings or furniture. So there was an interaction between the volunteer and that sentience in the state. There was the maintenance of a personal self, a personal ego with which one negotiated that state, interacted with the beings, looked left, looked right, would ask questions.
So the them of them was present in this experience. They were aware of still being themselves. They just were in a different world.
Is that the right way to describe it?
Absolutely. They were themselves in a different world. Both the volunteers and I expected the wild ego death, default mode, network blowout kind of experience, which all of us were kind of, weaned on in our 20s. The mystical experience, the enlightenment of Buddhism, a Kensho, no form, feeling, consciousness, perception, or cognition. But I'll tell you, in almost 5 dozen volunteers, the only person with that kind of an experience was a religious studies major in college who had always wanted that kind of an experience. So I was expecting the inherent nature of the drug to lead to a particular kind of experience, the enlightenment experience. I was trained and studied Buddhism for a couple of decades. Most of our volunteers were meditators of an Eastern kind of tradition. But instead of the drug possessing an inherent effect or an inherent experience, the drug just shone an atomic spotlight on the character of the person. So that was okay. So anyway, so people start coming down at about the 5-minute point, maybe 7-8 minutes. They start to feel their bodies coalesce. They're able, they're conscious of their breathing, which they weren't for 5 to 8 minutes or 10 minutes or so. They would take a deep breath, move their fingers, move their toes. In a way, it was like they were being reborn, reconstituted. And they would start to talk at the 20-minute, 25-minute point. Some people wanted to stay stay silent for 30, 40-minute point. We would usually rouse people at around the 40-minute point if they hadn't started to speak on their own again. And they'd be answering questionnaires, drinking tea, eating breakfast at about the 40 or 45-minute point in most cases.
Do you see any medical value in the drug that you studied?
Yeah, I do. Although it's not quite as straightforward as the case with the longer acting orally active drugs like psilocybin and LSD. First of all, it's quite short acting, and there's not much time to orient yourself in that space. It's hard to establish communication with the beings. The language of interaction wasn't especially obvious to the volunteers in their relation to the beings, and by the time they started getting their bearings, they came down. So that's one of the problems, is it's quite a short duration of action. But nevertheless, I mean, I've gotten 10,000, 12,000 emails, from people since the DMT book came out. And
that book is called, that's DMT, the Spirit Molecule, right?
Right. It came out in early 2001.
Yeah, I just want to make sure you get a chance to plug it.
Right. And I'd also like to, plug the independent, documentary that was, based on our research. It's also called The Spirit Molecule. I think you can't stream it anymore on, Netflix, but I think that's because, Warner Brothers bought it back or took it back.
I watched it it's on YouTube. It's available on YouTube.
Okay. Yeah, you can watch it on YouTube, and once, the Warner streaming service gets up and running, it'll, probably be streamable there too. So I've, gotten a fair number of emails from people who, have smoked DMT once, and they stopped using drugs, or they stopped drinking, or their depression just just evaporated. So even a one major DMT experience can make a huge difference in selected individuals. But I would say in most cases the brief duration is a cap. We gave big doses of DMT 4 times in a morning in what we call the tolerance study, to see if closely spaced repeated dosing would reduce the effects of DMT. With LSD, you give it every day or you take it every day, it just stops working after the 3rd or the 4th day. Just, no effect, hardly at all. Same with, psilocybin. But that hadn't been established with DMT. Even in cats, giving it every, 2 hours for 21 days straight, there wasn't any tolerance.
Wait. You dosed a cat?
Well, there were studies, trying to establish DMT, tolerance in the 1970s, and there was a study at the NIH in the early 70s. No. That study was a Case Western.
I know this stuff is serious, but what does a cat look like when it's tripping?
Well, you've got certain criteria to determine if drug is hallucinogenic in lower animals. There's a whole number of criteria, for mice and for rats. Cats weren't studied as much as rodents, but you could determine. I forget, like splayed paws, for example, in a cat, or it would be playing with imaginary mice, let's say, or hallucinated mice. Their paws might quiver, let's say, or they might shake themselves as like it. They might they might shake as if they were shaking water off of themselves. So there are a number of tests for psychedelic drug effects in lower animals. So there was a study, I think, Domino in Ann Arbor, actually, gave, DMT to a cat for 21 straight days, every 2 hours, and they were not able to demonstrate tolerance. So we, figured in humans, well, we could only give it every half hour because, people are still, stoned at the, 20-minute point. And we figured, 4 doses was, plenty, for, one morning. So number one, there was no tolerance. People got as high on the 4th dose as the first one. And, number two, there was this interesting, continuity in the experiences from the first to the, second, to the 3rd and 4th trips. So the psychological processes that were engaged in the volunteer the first time, they'd come down, we would talk about their experience for 5 or 10 minutes, get them ready for dose number 2. They go up there, process, come down, and we repeated it 4 times in the morning. So people were able to work through psychological issues that they were working on in their normal lives, like work or divorce or child rearing or things like that. So repeated dosing is one possibility to take advantage of potential therapeutic effects of DMT. The other is a continuous infusion study, which I proposed at the end of the DMT book, and it's being worked out right now at the Imperial College group.
Right,
where you give a continuous.
That somebody you can dose somebody and they can be in the DMT state for an hour or more. That's
well, theoretically, for hours or for days or for however long, because there is no tolerance. So you could keep people in that state for as long as you'd want, but you could also bring them out of it quite quickly, like within a few minutes once you turn off the infusion. So in a way, once that continuous infusion model is perfected, it will have advantages over, giving an oral, dose of LSD or psilocybin, because you can interrupt the trip and, speak with the person in a, sober state and say, well, what just happened, and, what was the, what kind of obstacles were you encountering, or what kind of breakthrough did you have, or what kind of questions weren't you able to address? So then you could put them, back in that state, right away. And I think you could get a lot of work done with that continuous infusion model that wouldn't be, feasible once you've swallowed the pill. Let's say for LSD, I mean, you're in that state. There's not much, coming down. Psilocybin, is a comparable effect. There is an orally active, preparation of, DMT out there too. It's called ayahuasca, which is a combination of two plants, from the Amazon. One contains DMT and the other contains an inhibitor of the enzyme, which otherwise would break down DMT in the stomach. So if you combine the two plants, one with DMT and one with the enzyme inhibitor, it allows the DMT to be absorbed from the gut into the bloodstream and gives you a fairly long duration DMT experience, 4 to 6 hours or so. And there's a slew of field information out there, empirical studies demonstrating if comparable beneficial effects of ayahuasca in a number of conditions comparable to those of psilocybin.
You had mentioned a few moments ago talking about the ability to pull somebody who is going through a continual infusion of DMT and stopping it and asking them. Can you talk about the concept of integration? Because earlier you said these drugs are not the cure; it's part of a holistic package of care. So can you talk about the work that needs to be done after somebody has a psychedelic experience to make sure that that person really gets the long-term benefit and not just had an interesting trip?
Yeah, well, the integration phase is the it's the third of three psychedelic assisted psychotherapy. The first is the educational aspect. In a way, it's indoctrination. You're being indoctrinated into a certain view of how psychedelics work, what they do, what to expect, what's the best approach to optimizing your outcome. You obtain a vocabulary. You learn some tools about what to do in the state once you're administered the drug. So for example, you're encouraged, to let go, as opposed to being encouraged to argue, which might be the case in in certain situations which would call for arguing, as opposed to letting go. The second stage is the actual drug session itself, in which case that is also steered in the direction which has been set up in the first phase, the educational and the indoctrination phase. So certain music is played to evoke certain emotional responses and not others, which is a very important issue, which isn't being addressed all that well. I mean, that music is being studied, but why that music, as opposed to other music, isn't really being investigated very carefully. And the final stage is to integrate what just took place. How to interpret what just went on and its impact, downstream over the next days, weeks, months, or years. How to understand it. How to deal with any questions that might come up. How to apply the insights in your everyday life, which is probably the biggest problem that both most recreational psychedelic users and those that participate in therapeutic studies need to face, which is, how to apply those insights. The thing that I tell people when they say, well, what do I do now? Or, how do I put this into effect in my everyday life? The thing I tell people, which is just, kind of, general at first blush, but is to, is to engage yourself in activities or, do things that remind you of that state, the, positive aspects anyway. Like, for example, if you had an enlightenment experience, you would want to then engage yourself in activities related to the enlightenment experience. You might want to begin, meditating within a religious stream that emphasizes enlightenment. You might want to work in a field or study, discipline that engages the mind in a way that mimics or attempts to approximate the enlightened state. You would, want to learn ways of being with people and the outside world and yourself, which mimic the enlightened state that you may have gotten a glimpse of on the drug. So you want to live a more psychedelicized life, which means you need to occupy to engage yourself with psychedelic things, at least things which appear or feel or resonate with you as psychedelic.
There is a tension in the psychedelic community, and there's really two tensions. One is between positioning these drugs as pharmaceuticals and that they should be used in a medical setting, whether it be the way you administered them in a hospital or in a clinic or with some medical intent in mind, versus making sure that these are just available to anybody who wants access to them. What do you think? Should these be the same way that cannabis is being positioned for adult use, that anybody who wants it should have access to DMT or LSD, or should they really be looked at more from a medical perspective?
Well, that's, the age-old conundrum. It was first articulated in the West anyway, as the debate between the lyrics, Tim Leary versus Aldous Huxley.
Right.
Tim was an egalitarian individual, said everybody should be able to do whatever they want with whatever. So Tim was all for widespread availability of psychedelics. He believed they were inherently beneficial, and any problems could be overcome, or there weren't any problems in the first place, as opposed to Aldous Huxley, who said only the elite should be able to take these drugs under very carefully monitored conditions, either religious or psychiatric. So that debate is continuing to be played out. Look at what occurred in Denver and in Oakland. In Denver, botanical or psilocybin mushrooms were decriminalized. In Oakland, every botanical psychedelic was similarly decriminalized. So that's kind of an example of Tim's approach being made more manifest.
Yeah, but Oregon's got a ballot initiative next year saying that for psilocybin, you have to go to a doctor, you have to be administered in a clinic. They're looking at it much more from the medical structure than what you described and what happened in Oakland, in Berkeley. I think Chicago as well recently passed an ordinance about the decriminalization. What is your take? I mean, you are eminently positioned to have an opinion. Do you have one?
course, yeah, I've been thinking about this from the get-go. Like should people like what is the best way for the most people to get the most benefit and the least harm from psychedelic drugs? I mean, I've been thinking about that since I was 18 years old. I think it depends. That's probably the best answer I can give in 2 words or less. Is it depends. You want to make sure that people are safe, which means that you want to know the source of your drug. You want to know that they're in good hands. So you would want some kind of certification of people who are going to be supervising drug sessions. I don't think that at this point just being able to get a prescription for psilocybin from your orthopedist who could prescribe it if they're rescheduled, and go to your Walgreens and pick up 5 grams of psilocybin mushrooms, and then go home and be expected to take care of yourself. I don't think that's going to be happening anytime soon. So I think it'll be important, if you want to optimize the effects, is to establish places and staff to supervise people's monitored sessions.
Well, and that leads to the other tension that's in the community, right? Which is the tension between those who want to do exactly what you said, have a medical structure, but provide these drugs for free, versus people like Compass and Atai and Field Trip, who are looking to treat this as a commercial venture. Do you have any thoughts on the for-profit model versus the not-for-profit model?
Well, I mean, obviously, the for-profit model has a different set of goals, different set of stakeholders than the nonprofit or the more altruistic model. I mean, you would want to pay for the service, but you wouldn't want to have to pay like $1,000. Donate. Donations appreciated. If the staff, this kind of ties into the staffing issue, like how well qualified, how expensive do you want your staff to be? Do you want them to be peers more or less that have taken maybe a 20-hour course, or do you want them to be MDs, or do you want them to be MDs and psychiatrists? Well, what about clinical psychologists? So that would determine the fee structure, even in a non-profit setting. If you're going to be making your living or spending a majority of your time as a staff person, you'd want to get reimbursed according to your own standards. So I think it's going to be a spectrum of clinical settings, especially in areas which have decriminalized these drugs. If you're only going to get these drugs through a prescription, then you're looking at the more medical end of the spectrum, where you would probably want more highly qualified people to supervise sessions.
Good. I mean, I agree with you, and I think personally that there is going to be a mix between the two models, between the USONA model, which is being done out of the University of Wisconsin, looking to create access to these medicines for free, versus what Field Trip is going to be doing, which is launching a series of initially ketamine clinics and then psilocybin when they can. Mike Tyson has been really talking about his experience with a different form of DMT called 5-MeO DMT, and there is a large underground community of people who are facilitating access to these molecules. Are you familiar with 5-MeO, and do you have any opinions about it versus the NM-DMT that you worked with?
Yeah, it's more potent milligram basis. A full dose of smoked DMT is 45 to 50 milligrams. A full dose of 5-methoxy DMT is closer to 3 to 5 milligrams. The acute effects are different. Generally, I mean, just kind of broadly speaking, the 5-methoxy DMT effect is more of the white light, ego death, mystical, unitive kind of experience. Not as frequently do people report encounters with beings as compared to DMT, which rarely gives you that white light experience and is more highly interactive and relational. So it's also needs to be either smoked or injected. It's quite fast acting, short duration of action. So much of what it's also endogenous. It seems to be also made in the human body as well as appearing in the plant kingdom. So I think a lot of what we were talking about, DMT as a therapeutic agent, applies also to 5-methoxy DMT. You would be expecting different effects. So you would want to capitalize on the influence or the interaction of the therapeutic effects you're looking for and the acute subjective effects that you're going to be encountering most likely. So you would tailor the drug for your desired outcome. You wouldn't be using DMT, let's say, if you want a white light experience, and you wouldn't be using 5-methoxy DMT if you wanted to do some problem solving with the beings. One of the things that I've heard of both on the internet and from my own acquaintances and from emails that I get is pretty intense 5-methoxy DMT, which isn't as commonly reported with.
Wait, can you repeat that, because I think you broke up for a second. So you, in the emails, you were saying.
Yeah, the scuttlebutt on the internet, nowadays, and the research papers which are coming out describing recreationally 5-methoxy DMT, and the emails I've gotten, acquaintances that I know that have smoked 5-methoxy DMT, is flashbacks are a lot more commonly reported with that drug as compared to reported with DMT. And those flashbacks usually are in the form of anxiety, panic attacks, fear, horror, dread, terror, and it can go. These can recur for a long time. I just heard somebody from the East Coast whose wife smoked 5-methoxy, and she's still having problems like 2-3 months down the road with these nocturnal panic attacks. And you just don't hear that with DMT. The first time I heard about 5-methoxy DMT was at a conference at the Esalen Institute in the early 1980s, and psychiatrist friend of mine smoked 5-methoxy DMT, was blown to bits in the white light, and was driving home on the Pacific Coast Highway a couple of days later, and just fell over. He lost control of the steering wheel.
God!
Flopped over to the to the passengers. Fortunately it was straight away, no oncoming traffic. He righted himself immediately, but still, I mean, that's not something that you hear is the case with DMT. I think perhaps the reason people are having these flashbacks with 5-methoxy is it's way easier to overdose on 5-methoxy. It's not much raw material that you have to get into your lungs. So I've heard people take twice as much as a full dose, 3-4 times as much. And it's quite difficult to inhale vaporized DMT to the extent that's required for a breakthrough experience. So it's much more, it's much more difficult to overdose on smoked DMT.
It's almost 20 years, or it's more now, more than 20 years since you did your research. I've got two questions for you. Looking back, what would you have done differently? And then do you have any interest in restarting your research?
Well, the main thing that I got wrong with my study was staffing. I didn't have a team around me that I could really rely on, that were peers, that could give me feedback, that could work with me with the volunteers, supervise the sessions with me, just give me feedback. I was a lone ranger out there, is very, very isolated. I got a lot of emotional support from my wife at the time and my friends, my spiritual community. But institutionally, academically, my chairman had no idea what I was doing. The research unit had no idea what I was doing, or understanding what it was I was doing, and they couldn't provide the peer review that I really needed. And once I got my studies going, the long promised migration of my colleagues from around the country never quite materialized. So I was kind of held holding the stick. I wasn't especially wedded to the psychopharmacology, brain chemistry model for a long-term view of the drugs. I was more interested in applying them to therapeutic or spiritual ends, but a one-man operation couldn't really pull that off. I mean, look at the Hopkins team, the NYU team. It's a lot of people. It's social workers, nurses, psychologists, psychiatrists. So the main thing is the team, the staffing issue. I didn't quite anticipate the need for that, and I didn't quite marshal it in time.
And if you had the opportunity, would you do more research?
Would I do more research? Oh man.
I mean, look, you've got a name. Tim Ferriss is throwing money around, like crazy. If you had the opportunity, if somebody came to you and said, I got $10 million, would you,
Well, 10 million probably is too much. 6 million was the number I was always, batting around. If somebody gave me $6 million and they said, this money is to put together the center of your dreams, I would do it.
And what would you study? Would you stay with DMT, or would you look at other things? What would you think your focus would be?
Well, I'm so it would be multidisciplinary, which would mean psychopharmacology. Let's look at how these drugs affect the brain and how different drugs affect the brain and the mind, differently. There's the classical drugs, the ones that are found in nature, and there's synthetic ones. The synthetic ones you can tailor make to impact certain receptors and skip other ones. So it's what's called structure activity studies. You compare or you correlate the structure of the chemical with the activity, which is the subjective effects and the biological responses. I would be interested in the psychotherapeutic applications, and I wouldn't just be throwing drug effect at everyone under the sun, which is kind of what is a tendency in this early stage of applying these drugs effects to psychotherapeutic ends. The most striking example is the mystical experience model that's come out of Hopkins. They are positing that a mystical experience is therapeutic. So what conditions are hard to treat? Let's throw the mystical experience at it, and we'll expect some benefit. But the mystical experience isn't the only type of big psychedelic experience which is possible. So the interactive relational experience that's more common with DMT might be as beneficial as the mystical unitive one, depending on the condition, the inclination of the patient, the training of the therapist. There are spiritual applications. Can these drugs enhance spiritual progress? And I think when you start to look at the beneficial effects of these drugs, you want to look more at the mechanisms of how they affect the desired outcome. The mystical experience is only one type of outcome, which is primed by all the pre-session educational and the expectation building that occurs before the actual drug session. So you look at the mystical model with the preparation and the desired outcome model with the preparation and the desired outcome. You look at how many conditions are improved by the administration of psychedelics, eating disorders, OCD, addictions, alcoholism, tobacco dependence, eating disorders, depression, end-of-life despair. You start to think of these drugs as panaceas, and panaceas work through the placebo effect. And there's a lot of interest now in the placebo effect, the biology, the way in which the activation of the placebo effect mobilizes our inherent healing mechanisms, immune, endocrine, stem cells, all kinds of inherent healing mechanisms which are activated through the placebo response. So if psychedelics are they appear to be panacea-like, they will basically do whatever you want them to do. If you prime the pump that way, they'll make you into a dedicated serial killer. If you take them with Charles Manson, they'll make you an enlightened individual if you take them in a different kind of a setting. If you combine them with a mindfulness meditation retreat, your mindfulness meditation will be supercharged. So I think these drugs are actually super placebos, and that's why we are seeing this huge spectrum of effects of whatever you're looking for. You'll find whatever you want them to do, they will do. So I think rather than selling an effect of the drug like an experience, I think we need to bore down a little more closely into how they do so many things for so many different people in a very effective manner, which would then make us look more carefully at their placebo enhancing properties, and to turn those to any condition where a placebo effect will enhance your outcome, like chemotherapy for cancer. Like if you're in a great mood and more optimistic, and you're marshaling your own healing responses, that can't help, it seems to me, but buttress or augment the efficacy of cancer chemotherapy, psychosomatic conditions like asthma or skin reactions, connect collagen vascular autoimmune diseases.
Yeah, Andrew Weil says that he took when he was at Harvard, he took LSD, and he had been allergic to cats, and after his trip he was no longer allergic. I mean, that is a perfect example of I think what you're describing in terms of the placebo effect. And people just dismiss, oh, it's just the placebo effect. Isn't the point of any of these things to actually get the end result? I mean, the point of any medication is to treat an underlying issue. And if by taking a psychedelic, what you're doing is allowing your body and your mind to work more in harmony to treat it itself without another external drug, then that's better, I would think.
It's a lot larger than simply you'll have a particular experience on these drugs and that's curative. I think that's kind of a blunt-edged instrument. Because what happens if you don't have that experience? If you're primed to have a particular kind of experience and you don't, then you might feel like a failure and end up even worse off than you were before.
And is that a function of your mindset going into the experience? Like if you go into the experience with a clear intention, that my understanding is that has a stronger impact on the outcomes if you do the integration work after than if you're just going into it going, let's see what happens.
It's a combination of things. That's the expectation of the person, their experiences, their goals, their hopes. That's what you would be calling the set. But it also relates to the setting, which is the expectations of those that are giving you the drug. The Johns Hopkins and NYU papers a few years ago describing terminally ill. If you look in the supplemental materials that were included in the paper that came out from the Hopkins group, there was a suicide in their group, and they say, well, it was a low dose of drug, so it wasn't the drug. But I spoke with someone who's got firsthand knowledge of that patient, and what is the case is that patient, given a medium or a lowish dose of the drug, did not have a mystical experience, which everybody was saying. You have a mystical experience and you'll no longer be depressed about dying. You'll accept your death with equanimity. Your pain levels may go down. Your use of narcotics may go down. Your depression may improve. And that's all tied into the curative and healing powers of the mystical experience. Well, this poor lady got a low dose of drug, didn't have a mystical experience, felt like a fan, ended up killing herself within 2 weeks. So I think the let's give you the drug and you see what happens, that's not such a bad way of giving psychedelics. If you've got experienced clinicians in the room with that person.
Can I ask a personal question? And you don't have to answer this, and if you don't, I'll just cut it out. What is your experience with psychedelics? Do you mind talking about that?
Well, I would a lot more time than we've got. I mean,
take all the time you want.
Yeah. Well, a few months ago, I did an interview with Graham Hancock, and I spoke about my experience using DMT, my first exposure to it, under the watchful eye of Terence McKenna in 1986. Yeah, so I do talk about that experience, and yeah, it completely shook me to my core. I mean, I was studying melatonin and the pineal gland at that time, and I was pontificating about the spiritual characteristics of the pineal, and I gave a talk at a conference where Taryn, and he said, yeah, I encountered these beings that coalesced out of this waterfall of flaming colors, and they kind of were 3 feet high, 4 feet high, just a half a dozen of them, not many. And they just, bored into me this question, now do you see? Now do you see? Over and over and over again. I came down and to myself, what was that? And, changed, career, directions within maybe 3 months. I, dropped the melatonin work, dropped the pineal work, and began working on the DMT study. This was 1988.
Do you see, what were the lessons that you've personally learned from your psychedelic experiences? And then do you still look to these molecules on occasion to revisit those lessons if you're feeling like they might be slipping?
Well, you asked about other psychedelic. There is a legal ayahuasca church, based in Santa Fe. Mm-hmm. And I was for a few months, 2013 to 2014, and I drank a lot of ayahuasca, with that church, completely legal, completely above board. So I got a fair exposure over a short period of time to ayahuasca, and of course I dabbled in college, as most of us did. But it's been, it's been, some time since taking a psychedelic. At a certain point, you learn to remind yourself of that state without the drug. Although I think that, varies from person to person and at various stages of one's life to other stages. Like, Ram Dass always used to say, I would take a big dose of LSD once a year just to recalibrate and, check in. For some, people, that's a great idea. And, for other people, it isn't necessary. Once I started to study the Hebrew Bible and kind of get into the prophetic mind and really study the text, that reminds me of a particular way of understanding reality and our relationship to it that is, psychedelic enough for me, at least, for the time being.
What are you working on now?
Well, I got quite ill in 2014. I got pneumonia and then a superbug, and I was quite sick, and it took me a long time to recuperate. And the health care that I got in a small town, Southwest, wasn't that great. So I, took a lot of notes, and I thought if I survive this, I'm going to, fictionalize it slightly, and publish it. Yeah, so my first, novel came out in March. It's called Joseph Levy Escapes Death. It's an account of my alter ego's adventures with being quite sick and then recovering. So that came out in March, and I'm working on of other writing projects, like another installment in the Joseph Levy story. I'm also fascinated by the character of Abraham in the Bible, and I've been taking a lot of notes about him for a number of years, and hope to see if I can make a stab at biblical fiction. A more sophisticated maybe, or an upper cruster approach, compared to the Red Tent, but of that ilk, like fictionalized expansion on biblical narratives, and especially around the figure of Abraham, the first the first Hebrew,
and the first person to trip, right? I mean, that's how you just I think you've described him as his mystical experiences may be related to DMT.
In the Prophetic States book I wrote in 2014, DMT and the Soul of Prophecy, I speculate that certain aspects of the prophetic experience, the visions and the voices, could be mediated through the release of endogenous DMT, not through any plants or drugs that the prophetic figures took, but produced in the human body. Prophecy, as I understand it, is any spiritual experience that is had by any figure in the Bible. So strictly speaking, the first interaction between man and humans, or between humans and God, was an example of the prophetic experience. So when God speaks to Adam and Eve and says, "Be fruitful and multiply," that's God speaking to humans, and humans hear it. So that is a prophetic experience. So anybody that speaks to God or his angels is inspired, has visions, voices, out of body experiences. Those people are experiencing prophecy. So the character of Abraham, lived a prophetic life. He was the first Hebrew, the first Jew. But it was before the laying down of the Mosaic law with the Ten Commandments and the precepts, the mitzvot. Those were all laid down by Moses. Before Moses, there wasn't any law. And Abraham, as the first Jewish person, followed the law, so they believe, without it being written down. It was intuitive. It was as a result of his ongoing relationship with God rather than his adhering to a doctrine or a text. So I'm fascinated by the idea of the first really hardcore Jewish prophet and his life, and how he decided to do the things that he decided to do.
Well, it's just me. I've taken enough of your time. I just want to ask one final question. The 60 Minutes recently issued or did a segment on psychedelics. The Today Show recently did a segment on psychedelics. You've seen coverage of all of the work being done at Johns Hopkins and the $17 million that Tim Ferriss brought to bear. What is the one story that you think the media is missing about these medicines? They're not doing it in a tongue-in-cheek fashion. It's not a lot of, images of the 60s, but what are they missing? What is everybody missing?
Well, they're skipping over one thing, and they're missing something else. The skipping over is their dark side. Their potential benefits are being glorified, and their adverse effects are being minimized. For example, their benefits are being couched in frames like mystical experience, and the adverse effects are being downgraded to challenging experiences. Like, for example, my drip irrigation system, and it's leaking everywhere. That's a challenging experience. Permanent psychosis, which can occur in a vulnerable person who takes psychedelics, isn't a challenging experience, even in the questionnaire and in discussions. Well, there's two potential downsides. One is the adverse effects. If somebody isn't screened adequately, let's say that they're teetering on a psychosis, for example. they are getting paranoid. They're not eating so much. They can't quite, tell if what they are hearing is real or not. They're secluding. Yeah, you wouldn't want that kind of a person to take LSD. I mean, chances are it would flip them into a full-blown psychosis. That's the most extreme case of an adverse effect. In an acute adverse effect. The other adverse effect. There's a slew. One of the potential adverse effects is the adverse effect of the model in which the drugs are being given. So, for example, you might not attain a mystical state in a mystical state-oriented, research center, and feel like a failure and end up killing yourself. So that's an adverse effect of the setting in a way, interacting with the acute drug effect. I think also too, if we're going to make these drugs more available, we'll need to prepare for fallout on their misuse. For example, psychedelics are being used by these far right ultra nationalist vigilante organizations to cement their beliefs. Make them dedicated followers of a particular worldview, like Manson did in his followers, the model of helter skelter, and they're still being used in that way. So if for example some crazy thing is done by some crazed person who is a member of a group that uses psychedelics in such a manner, it's going to be important to differentiate between this is not an inherent effect of the drug, it's just the way in which it's being used. So that's an issue regarding a more balanced, less starry-eyed approach to how these drugs are being mainstreamed right now.
Well, I think that was great, and I really appreciate your time. And as soon as I know when this is going to publish, which should probably be in about a month or so, I'll let you know. Is there a Twitter account or some place that I can point people to so that they can get access to your books or follow you? I don't know if you have a social media presence.
Yeah, I have a personal page and a public page on Facebook, and I have a website, rickstrassman.com.
Okay, great.
So, yeah, I correspond with a lot of people all the time. A few emails every day from folks who want to talk things over. You can buy my books from me through my website, which I would then inscribe and sign. So that's an advantage of contacting me directly through my site.
Okay.
Oh, one extra point about the media is they're kind of skipping over the adverse effects question, but I think in their rush to glorify these drugs, they are, I guess, skipping over the more important questions about how they work, rather than that they work through causing a mystical state. They may work through the enhancement of the placebo mechanism, but that's kind of more sophisticated approach to things, more than more so than the mainstream media and your average reader would want to take on.
That is perfect. Thank you so much. I truly appreciate you taking the time with me. A special thanks to Dr. Rick Strassman, who is, as I hope you heard, one of the most interesting and important people in terms of psychedelic research. You can reach out to him at Rick Strassman, it's RickStrassman.com. And if you haven't read his book, the Dmt the Spirit Molecule, it would be wise for you to do so. As always, if you want to chat with us, you can find us on Twitter with the handle @the_greenrush or on Instagram @the_greenrush_podcast. As always, drop us an email at greenrush@kcsa.com. We're always looking for feedback and guest ideas. And please don't forget to subscribe to The Green Rush in your favorite podcatcher. That's one take, Shay. One take.